Hello, today I'll be presenting about the global burden of malaria, specifically in Uganda. Malaria is one of the world's oldest and deadliest infectious disease caused by Plasmodium parasites and transmitted through the bite of Anopheles mosquitoes. Despite being entirely preventable, it remains a major global health threat, especially in tropical regions. Globally, malaria ranked fifth in disease burden and sixth in infectious disease mortality. But the burden isn't equal. In 2023, 94% of malaria cases and 95% of deaths occurred in Africa. Uganda ranked third highest on the continent. That means over 12 million cases and nearly 16,000 deaths in 1 year alone. Every person in Uganda is at risk. Pregnant women, children under 5, and travelers are at most highest risk. What drew me to the issue is not just its scale, but the injustice behind it. Malaria is preventable. There are many medications, mosquito nets, and evidence based strategies, and yet it continues to devastate low and middle income countries, while disproportionately affecting children, women, and the poor. That raises a serious question: if we have the tools, why does malaria still persist? Uganda caught my attention when I discovered it received over 115 million from the Global Malaria Funds, which is more than Nigeria, which is ranked first in the global malaria burden. That made me wonder what makes Uganda's situation so complex and how can nurses make a difference there? This issue speaks directly to the heart of global nursing. It's about health equity, resourcefulness, and culturally responsive care. Nurses in Uganda aren't just treating malaria, they're educating communities, detecting early symptoms, and managing care with limited supplies. Their strategies offer critical insights for nurses in other low resource or emergency settings. As climate change and globalization continue to spread diseases across borders, malaria is no longer a distant problem. Nurses everywhere must be prepared to respond, whether in Kampala or Toronto. Addressing malaria in Uganda is a powerful example of how nurses can lead in strengthening global health system and advancing health equity. To understand the burden of malaria in Uganda today, we have to look back because malaria isn't just a disease, it's a legacy of power, inequality, and structural neglect. Malaria existed in Uganda long before colonization, but under the British rule from 1894 to 1962 it became a political problem. The colonial government focused on protecting Europeans, not Ugandans. They built closed housing, distribute quinine, which is a treatment, and managed mosquito habitats for settlers. Meanwhile, Ugandans were left exposed and even blamed as reservoir of the disease. Colonial infrastructure projects like railways, plantation, and forced labor created mosquito breeding grounds and pushed malaria into new regions. This action laid the groundwork for today's health inequities. And although colonizers left, their influence didn't. High income countries could still control much of the global health funding, research, and policy, while Uganda remained donor dependent. 1950, Uganda hosted the WHO Equatorial Africa Malaria Conference. This led to new eradication efforts in the 50s and 60s, but weak health system meant they didn't last. After independence in 1962, political instability and war collapsed Uganda's healthcare system. In the 1980s, structural programs imposed by the IMF and the World Bank forced Uganda to slash public spending, weakening healthcare even further and worsening poverty. By the 1990s, donors stepped in. The Global Fund, WHO, PMI, Gates Foundation all played major role in reviving malaria programs. Uganda adopted decentralized primary care and scaled up interventions like bed nets and drug access. But here's the catch: over 90% of malaria funding still comes from donor. That makes process fragile, and priorities often reflect external interests, not local needs. On the ground, nurses, village health teams, and communities do the real work, but districts still face underfunding, staff shortages, and weak data system. Donors' metrics often focus on outputs like how many nets were handed out rather than long term outcomes, and corruption like embezzlement and ghost workers has diverted vital resources and damaged public trust. Malaria in Uganda isn't just a health issue, it's a story shaped by history, politics, and power. Until these deeper roots are addressed, malaria will remain more than a mosquito borne disease, it will remain a systemic injustice. Malaria doesn't spread randomly. It follows the contours of the land, the weather, and even our beliefs. In Uganda, the environment and culture create the perfect storm for malaria transmission. Uganda's warm, humid climate and double rainy season provided year-round breeding grounds for mosquitoes. Add to that water-abundant areas like lakes and wetlands near crowded towns, and mosquito-to-human contact becomes almost constant. But it's not just nature. Rice farming, deforestation, irrigation, and rapid urbanization have expanded mosquito habitats. In slums where drainage is poor and housing is formal, people are most exposed. In fact, malaria rates in informal settlements are significantly higher than in planned areas. Climate change is also shifting malaria into Uganda's highlands, areas once considered low risk. Displacement and global travel have also helped malaria spread into new zones, even reaching non endemic regions. Culturally, beliefs matters. In many Ugandan communities, malaria is seen not as a medical condition but as a curse or a spiritual attack. So people often turn first to traditional or herbal remedies, delaying medical treatment. Also, others may discourage hospital visits. Caregivers, especially women, may lack the power or money to seek care. In some regions, women need male permission just to go to a clinic, and in many homes, men get the bed nets while women and children sleep exposed. Even when people are trying to get help, they face more obstacles like distant clinics, medicine shortages, staff and strained staff, and poor roads. These aren't just inconveniences, they're forms of structural violence that delay care and increase deaths, especially for the poorest and most vulnerable. To fight malaria in Uganda, we must go beyond the mosquitoes. We have to address the environment, the culture, and the system that allows malaria to thrive. As a nursing student immersed in global health, I've come to realize that fighting malaria in Uganda is not just about medicine. It's about leadership, ethics, and deep community connection. Nurses are just not caregivers. We are educators, advocates, collaborators, and system changers. Nurses are often the first hand and sometimes the only line of defense. In clinics and villages, they teach families how malaria spreads, how to use insecticide treated nets, and why stagnant water is dangerous. This isn't just public health, it's empowerment. But cultural beliefs complicate this. Many families believe malaria is spiritual, caused by curses or imbalances. Nurses must walk a fine line, respecting tradition while advocating for timely biomedical care. This is where ethics meet empathy. In rural Uganda, nurses often diagnose and treat malaria without doctors. They rely on their training, judgment, and limited tools, sometimes deciding who gets the last dose of antimalarial medicine. These are real ethical dilemmas born from systemic shortages. The brain drain only make it worse, as nurses leave for better paying jobs abroad, leaving those who remain overwhelmed and under-resourced. But nurses are not just responders. We are data collectors, reporting malaria cases to guide national policies. We are advocates, raising the alarm when communities are overlooked. Yet, too often, nurses are excluded from decision making tables. Without our voices, programs miss the mark. We must be involved in shaping the policies we're expected to carry out. Well, there is good news. There are growing opportunities from online training modules to mentorship programs. Nurses can build leadership and skills even in rural areas, but we cannot do it alone. Collaboration is key. Working with doctors, traditional healers, NGOs, even international partners like WHO or ICN to co create programs that are culturally rooted and evidence based. We nurses are not just part of malaria response, we are the foundation of it. With the right tools, training, and seat at the table, we can drive lasting change. Because when nurses lead, community thrives, and malaria gets defeated. Thank you so much for listening to my creative synthesis. The following slides are the images links. Thank you so much and have a great day.